I know that we have very little time between now and the break. We're a little bit late, but obviously my job is simply to try and get further clarification or pearls of wisdom from our panelists based on the questions you ask. And I don't really have a question at the moment, but if anyone wants to jump to the mic, and I see someone going.
Thanks. To any of the panelists, I think, we always, at least I always look at, the table 1, race, gender, ethnicity. Why don't we push the FDA and say, we want our trial populations to mimic the U.S. population so that we feel confident when we're prescribing drugs?
Can I make a comment on it? So I worked with All Hat. I was on the DSMB for All Hat. And the NIH, in their particular studies, make sure if you have a disease, in this particular case it was hypertension, that you have adequate representation or even over-representation. The reason they probably don't do it with industry is because industry has to get their trials done within a certain period of time so they can get their patent and make money. And what they'll do is they'll go to Eastern Europe or wherever and get as many patients as they can, and then get the patients approved by the FDA and get the new drug. You have some drugs that really have very, very little diversity, and they're approved in the United States. What we need to do is push for the FDA to do that for industry trials, but they do it for their own studies.
Yeah, yeah.
My other answer to that question is also I was on the panel back about 15 years ago, and of course we tried to mandate that in NIH-sponsored trials, but of course the IRBs do not allow you to mandate. So that was all you can do is encourage and go harder and seek out, but you're not permitted to mandate because everybody would somewhere along the line force someone into a trial, of course, inappropriately. I'm going to start with one little quick question to illustrate on the theme of women and how the guidelines, as everyone knows, were developed based on men for heart disease. And clearly that's because the peak time for heart disease in men is about 58 today. For women, it's 68, 10 years later. And I'd like to look at that and think about it and see what the panel will do. Here's a classic case, 42-year-old female who comes for a routine checkup, has no symptoms, she's examined, blood work is done, her only abnormality is an LDL cholesterol of 180. Then the doc who is busy, whether he's a primary care physician or a cardiologist, who knows his stuff, looks at his guidelines and says, there's nothing here for us to treat, so come back and see me if you have a heart attack or if you develop hypertension or if you get 50 pounds overweight or something. That person, to me, that's the state of the art in 2021, according to the guidelines in the United States and Canada, and most of Europe is the same way from that point of view. So my point to you, I think we really missed a big opportunity here, don't we? Women in their 40s have very little disease. We have armamentarium today to probably prevent 40 to 60% of it without the newer drugs. So I'll turn to the panel and get their thoughts on what they would do for this lady. Come on.
Go ahead. I can start. So, yeah, you're right, Dr. Roberts. So unless the LDL is 190 or above, we wouldn't start a statin in this patient. So I think with the new chest pain guidelines, the next step would be to actually assess the coronary arteries, either through calcium score or coronary CTA. And if there is any obstructive or non-obstructive disease, based on that, I think starting a statin early, that would really help. I think the Warrior trial, once the results are out, that could really help with that.
Thank you. Go ahead, Parapid.
Thank you. I think that I would start with some lifestyle measures, try to change her diet this way or the other is going to help her in the long run. Hopefully look for something if pure plant-based is not affordable for the region, or, in Serbia now it's very popular that you eat plant-based or that you're vegan, and sadly it's mostly advocated by people who belong to a tier of the population who can afford themselves a bag of chia seeds that costs almost half of the salary of my nurse. But so let's try to be realistic about what we are offering to our patients, but something that is the healthiest that the person can afford themselves in their setting. That would be definitely my proposal.
Okay.
This patient, you're right, does not necessarily meet the guideline criteria, but the guidelines are imperfect. I would do family history. Family history is not in the guidelines, not because it's not a powerful predictor. It's because in 1948, with the original Framingham cohort, when they analyzed them, the family histories were so poorly taken that they couldn't use the data. In the Framingham offspring, family history is a positive consideration. And with the Reynolds score, you take family history, you also can add CRP. Another marker you could add is
So what I did with
lipoprotein
this
A.
42-year-old lady, I calculated out based on only the 180 cholesterol.
Yeah.
And as you know, the guidelines say you must be, the 10-year risk must be 7.5% or higher. So her guideline comes out at 2.3. Then I added a family history, it goes up to about 2.5.
Okay. Did you do a C-reactive protein on LPA?
No, because that's not in the guidelines to use from that point of view. You can't use that in the calculator.
We're imperfect beings with imperfect tools. And I sat on the National Blood Pressure Education Program for years. I was one of the chairs of JNC6 back in the day. And I can tell you that we don't have data and everything is not perfect. In this particular case, I would do some low-cost interventions, including a lipoprotein A once. It's a genetic marker with a family history. If she has a positive family history, it may be driven by LPA. We don't have a treatment for it, but it would increase her risk remarkably. HSCRP, Paul Ricker and his group believes in that. You could do it. It's not very expensive. And in terms of coronary calcium score, if you did it, it may not be positive because she's relatively young, but if it's 1, if it's 2, you're home free.
I agree. If the calcium score is certainly, to me, would be the one thing to do because it can fit into the guidelines which they've included and you could use it. I also want to point out one other defect in the system. That same lady, if she were 60 years of age and her only risk factor was a LDL cholesterol 180, she then goes up to 8.2. So the point I'm making to you is it is age dependent. It's most unfortunate. Fortunate in one way, heart disease in women could be really prevented. Unfortunate in the other way that we can wait until she gets 60 to treat her. My other point I want to make, because I really do have a soapbox on this one, you heard from Dr. Parapid saying I would do everything I could to change her diet or do all of her way of life in terms of those things. Now, when your LDL cholesterol is 180, I'm sad to tell you, but of course 75% of that level is due to your genes. And I can assure you, you're not going to bring 180 down to what we want is 70 by changing your diet. For example, remember, the country with the highest incidence of heart disease today lives, 840 million of them are vegetarians, at least they claim to be, India. And as you can see, 70% of your cholesterol is controlled by your genes. And unless you do something like taking a statin, you will not get 180 down to the guideline. Okay, I think that was a tougher issue from that point of view. I think one other question in terms of, we've been dealing with this problem in women since I've been around, which is twice the age of the oldest person here in this room probably. And, I really get almost tired of listening to it because I really don't know where we're going to go with it, except I would say, the calcium score is certainly a good thing to go for. But everything else is a little bit controversial and allows the physician to get off the hook. So I would say to you that until we have results from things like Warrior, I would urge all of you to think about the fact that in women, we have the opportunity that we don't have in men. I think all of you know that in the Vietnam War, the average age of a male was 19 years and 3 months. And those who died and got autopsies, all of them were showing some degree of atheroma.